Vaughan here to answer your questions. Let me turn the camera around and we can get started right away. Whatever it is that you guys have on your mind and talk about what's gone on since last time we were together. Paige Hannah, thanks for joining us. Roy1023, thanks for joining us. We're glad to have you here. I see some familiar handles there that I can't pronounce. Spirit1, thanks for coming. White, California Sherry, thank you all for being a part of Ask Dr. Vaughan. And thanks for the hearts already. That was really cool. I appreciate that. And good afternoon from Sherry. Yes, good afternoon to you too. And the person who I can't pronounce, invited followers. You know what I should do is I should just look over and see your profile so I can call you something like Sam D maybe. We'll call Sam D. Thanks for having your friends join. Oops, did I hit that right? Sam, there you go. Sam, let me look at you again there. Just make sure I have you in and I have you as somebody I'm following so that you can comment. So I do follow all of you who follow me so that you'll be able to comment, and of course you can give hearts whether you comment or not. And last night, many of you were probably around when I was at the pool party, able to do a Periscope there. Oh, well, thank you very much. That probably looks familiar to a lot of you because I don't have that many of them. The reason I wasn't swimming was because that was for the kids. The adults were just there to, be adults. But it was a good party, and the kids were good, and we didn't have to kick anybody out. They behaved themselves, so it was nice fun. Well, a lot of kids there. Some of you who saw on the video, you saw that maybe there were at least 30 teenagers there, all probably juniors and seniors in high school, but they had fun. And we were able to answer some questions. We did some questions on acetaminophen versus aspirin use. We did questions on gallbladder disease. We did questions on premenstrual pain and treatment for it with Midol and Pamperin. What type of doctor? Oh, now Sam, you haven't heard that before? Or are you just wanting me to say a good doctor? I'm a family medicine doctor in Auburn, California, in a family medicine practice called Auburn Medical Group. And if you want to know a lot about us, you can just look at auburnmedicalgroup.com if you're real patient for my very slow loading homepage. If you want to see some other things that we put out, you can look at medicallyspeakingradio.com or even askthedoctor.com. We have a lot of stuff out on the internet with information about our practice, and in an effort to get good medical information to people on Periscope and patients and others. So if any of you guys have questions about medical topics, we can go ahead and do that. Oh yeah, Sam, no problem. And It's Bird, thanks for joining us. We're glad to have you here too. Here we go. What's the best way to remove a callus on the thumb? It's different ways. Sometimes removing calluses can cause problems because they're usually there for a reason. There's an area of a lot of abrasion or a lot of pressure, and the callus is a development of lots of keratin, a protein that the skin produces to protect it. And if you were to take it off, there are a couple of reasons, a couple of ways it could be done. One would be using acid, like a wart remover type product that would wear it down over time, and eventually you can rub it off just like you would the keratin in a wart. It's the same protein. Another way would be shaving, actually taking a razor and shaving it off, which usually we see it with calluses. We usually see it done with feet more often than hands. And oftentimes a podiatrist, or rarely in our office, will actually shave down. And when we do shave, of course we clean it off first with antiseptic to make sure it's clean, and then shave it with a razor to get it to the point where you just start to see a pinpoint bleed, and then you stop because you're going to feel it if you go any further than that. And we'll do that in the office here. Whatever you do, if there's some kind of abrasion or pressure that the hand is exposed to, it's just going to come back. Lose brain cells during surgeries. Yes, you know who really talks about that is, I can't think of his name, but I can tell you the name of his book. The name of his book, Barry Friedberg? I think it's Barry Friedberg. Name of his book is Getting Over Going Under. And he goes into great detail about the concerns with general anesthesia and the popular monitoring techniques for it. And he promotes two things. One is, if it's at all possible to not use general anesthesia, to use sedation together with local anesthesia to get that done. And I'm trying to find even doctors in our area who will do this. The other thing that he recommends is using a different type of brain monitoring than is used normally in general anesthesia. Again, I don't see that being used. I've talked to actually local anesthesiologists who give arguments against what he is saying, and actually they have pretty good arguments against what he has, that suggests that what he's doing isn't necessarily avoiding the problems that are concerned. You asked about losing brain cells. There are situations where people will wake up from anesthesia and they're not the same as when they went under, and the thought is that they went too deep in anesthesia, that the monitoring that's currently done is not adequate for everything that can be going wrong during deep anesthesia. Again, I do recognize that there's something to it, that people who have been under anesthesia many times are at risk for having things occur that we can't quite explain. I don't know if Dr. Friedberg's explanation and his answer for getting around it is necessarily the answer that's going to solve the problem of changes in brain function after anesthesia, or mentation, or cognitive abilities. But I will agree that in my own experience, it does look like there may be something there. Of course, people are going under anesthesia have something wrong with them, and so there's lots of other things that could be going on, and it may not be the anesthesia after all. Friends having a bone marrow transplant at Stanford for lymphoma, can you describe the process? And somebody just completed surgery. The process of a bone marrow transplant, first they have to kill with chemotherapy all of the blood cells currently in a person's body, and then give them, actually it's just through an IV, give them the progenitor cells that will then produce all the different types of blood cells, and eventually they find their way into the bone marrow, and they set up shop there just like normal bone marrow blood progenitor cells do, and start producing new blood. And so it takes a while to build up a new blood supply of all the different types of blood cells from the different types of progenitor cells. Sometimes they'll use actual, well, it's a type of stem cell, but it's for the bloodline. Sometimes they'll use stem cell technology for it. Sometimes they'll use the person's own blood cells. Sometimes they'll use that of a close relative, an HLA match, which I believe is about, was it 1 in 4 siblings about are a match? Don't quote me on that. Being a donor is more painful than being the recipient. Yeah, and sometimes people are their own donor, actually. Yeah, the donor process, you have to do a bone marrow biopsy, which is taking best way I can describe it is a corkscrew. A corkscrew into the hip from behind. The person lays on the table and they turn it in to get into the hip bone, because inside of that hip bone is where the bone marrow is that they're going to draw out. And then when it's injected, it finds its way into all the bone marrow and all the long bones in the body. Actually, I have heard of 2 people who do that procedure in my town. One of them is ouch, and the other one is no big deal. He numbs you up before he does it, and you know that something's going on because your body's kind of moving around as he's actually getting into the bone, but not terribly painful after you get numbed up for it. Test for PCOS, and should it bring up to my doctor? PCOS. 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 Postcoital ouch syndrome? No. Runs my family as well as thyroid issues and endometriosis. PCOS. Polycystic ovaries. Thank you. Polycystic ovaries. I have not had many patients with it, and those I've had, I've actually had a consultant, either an endocrinologist or a gynecologist helping with it. And all I have seen is that generally they'll treat with metformin to help control blood sugar levels, but also plays a role in helping with the other symptoms related to the hormones of the polycystic ovaries. It's not unusual for somebody to have an ovary operated on because of the polycysts, or the many cysts. And that's about the extent of my familiarity with polycystic ovary disease without reading on it. If I had a patient who came in with it, I would be, on the computer here, getting updated on what the latest is on it. Autoimmune decrease with age. I've seen it go both ways, but generally you see people better able to live with autoimmune diseases as they do get older. Autoimmune disease usually hits in the 20s or 30s. Most people, it can be younger, and is a disease of the person having antibodies against their own body's tissues, and so there's attacking going on and destruction of the body's tissues. The most known is rheumatoid arthritis, where the actual joints, lining of the joints is attacked by the white blood cells. Thank you, Sherry. I really appreciate your call for hearts, and we love to get them. Somebody has ITP, idiopathic thrombocytopenic purpura, disease of the blood, where you have problems with the blood clotting and will actually have a paucity or a decrease, a low count of the platelets that are involved in blood clotting. You'll get these blotches of bruising all over the body called purpura. And it is most often treated with steroids, and oftentimes resolves just fine. And then there's a worse version of thrombocytopenic purpura called thrombotic thrombocytopenic purpura, where people have problems with getting clots and at the same time have the low count of the platelets. My specialty is family medicine, Jackie, family medicine. A bit of my background, though. I did do an emergency medicine residency and maintain my board certification in emergency medicine, so I have a bit of a hand in both worlds, family medicine and emergency medicine, which I feel makes me a better doctor for my patients, to have the more extensive and broader familiarity with medicine. But both of them are still rather broad specialties. You know, they kind of cover everything. Emergency medicine covers emergencies and everybody, anything that can come in the door. Family medicine covers that plus, well, not so much that, but more covers anything that come in the door, but not an emergency department door. GP in the UK, also they refer to it as GP here quite often. It's just everybody does a residency nowadays in medicine, and family medicine is the name that was applied to the GP of old. Okay, guys, I have patients to get to, so I appreciate you being here and having some questions. Right, yeah, if the blood's been worked up, you've already checked for all the bad things, so you're all right on that. Thank you, you guys are so nice. And Elsa Jenny, I'm sorry you joined right as I'm signing off. I'm also sorry I'm leaving right as all the hearts are coming back. I got to run, we got things going here in the office. Be back in the future. Of course, if you don't already follow, just swipe right and follow. And tell your friends who have any desire to talk about medical topics with us. Okay, yeah, you guys have a good afternoon too. Thanks for inviting the followers, although we're taking off right now, but we'll be back with future episodes in coming days. See you next time. Until then, this is Dr. Mark Vaughan telling you to stay in good health.